Good morning, welcome. Thank you for sparing some time out of your busy days to attend the session, which we hope will be more kind of an informal feel. Really keen through this session to be able to stimulate some kind of conversation between ourselves about how we can learn from each other. So my name's Chris Knight. I'm currently a programme director within the Trust, and I'll come on to tell you a little bit about what I'm doing. Can I also introduce to you, or she could introduce herself, Adele, are you there? Could you say hello? You're on mute.
Apologies. I'm hoping everyone can see me. It's a little bit dark in this room, isn't it? Hi, I'm Adele Sabin. I'm a programme manager in the Trust at the moment for the Acute Care Modernisation programme, which I'll talk to you about in a little while.
Fab. Conscious is quite, but if we were all in a room together, we might kind of look across and say hello. So I just want to encourage you in the next few moments, maybe in the chat bit, to say hello to people, maybe say who you are, maybe why you're here, what you're doing for the weekend, but just, for the next few moments, if you can have one eye to typing and saying hello, introducing yourself, and one ear to listening to what I say by way of just setting the scene a little bit. So just encourage you to do that. And, as I say, this world of virtual reality is one that shouldn't be void of just the personal bit and the interaction. So just encourage you to do that and say hello to each other. So the aim of this session is twofold, really, is to provide a little bit of information around some programs that are currently going on within the Trust. And we're going to zoom in the time that we've got available to two in particular. But as the first slide will show in a moment, there's a number that are going on. But probably more importantly than that, we want to try and stimulate some conversation with each other around what are the ingredients for successful programs that are about transformation, and what are some of the pitfalls and some of the failures that we can, in the context of a QI week, be learning and shaping and listening to each other. So without further ado, there are some slides. We're going to kind of try and whiz through those slides. There's a video in there as well, which hopefully might be a bit more interesting than the monotony of my voice. But if you could just, and this is the point at which I'm going to start to feel a little bit like one of the Prime Minister's sidekicks. Joe, could we have the next slide, please? Oh. Okay, so
I just changed the layout of it a bit, Chris, if you're looking surprised.
Yeah, I was like, oh, I'm not prepared for this one.
Information, I just made it look a bit, yeah.
That's fine. Okay, so what you're basically looking at here, as much as the session's called the Big Six, for those who were in the earlier session, the CMHT one that Helen was fantastic in talking about, we wanted to just zoom in on very quickly the other six, which are significant in each of their own rights, and they are all very different in terms of the flavour of what each of them are trying to do. And then we're going to have a quick look at the purple two in a little bit more detail. So leaving Fulwood, I'm sure most people are aware of that and the transition and the move away from Fulwood as that site is sold off. The Acute Care Modernisation programme, which Adele will share a little bit about. This morning we heard, as you say, about the Community Mental Health Review. We've got the EPR, Electronic Patient Records programme, which is going to be significant. And for those of you who've worked in other NHS organisations, ears might well prick up and, oh, we did one of those and it was great, or we did one of those and oh my goodness me. So that's certainly a space to watch. The people plan, the heart and soul of what we're doing. I had the privilege of working with Pranav Izar in my last role, who's the Chief People Officer at NHS England. And if you haven't read that plan, I would thoroughly recommend you at least look at the executive summary of it, because that will be fundamental to the shaping of how we provide patient care. So there's a very focused piece of work there that Rita Evans is leading on. the Adult Secure, which I'll come on to in a moment, and then the Primary and Community Mental Health Programme, which again is around bringing systems and people together to try and improve on care provision. So a whistle-stop tour of the 7. I'm sure that in the context of if you're interested into any of those others in a bit more detail, my kind of steer would be make contact with one of the team at the PMO that Zoe and the team lead, and I'm sure that they will be more than happy to either put you in contact with or share a little bit more about what those things are. So next slide, please.
Sorry, Chris, I am trying. Let me, there we go. Have I missed one?
Okay, right, great. So this is the first of 2. We're going to do a quick rattle through them because, as I said at the beginning, the aim is to try and stimulate some conversation between ourselves. So this is the programme that I'm currently overseeing as programme director. So what's all this about? So you'll be familiar with the NHS long-term view. There was something else that was referred to, which I'm sure many are familiar with, around the mental health 5-year forward view. And within that, there was a very clear focus around trying to support a fairly small group, but a very complex group of patients, referred largely to as those that are in forensic or secure settings. So these are patients that with complex conditions, such that they would either be, because of their conditions, in a prison setting or within a secure setting. So the NHS are leading a national programme of change, and largely what that national programme is seeking to do is to move what's currently being commissioned by specialised commissioning to a number of providers, and to migrate that into lead providers, and we're one of those. There's 45 in the country. The provision of that care to be moulded together around a kind of a network and a collaboration that helps us to reshape the provision of that care. And I guess the headlines of that, and it will be explained in the video in a moment, the headlines really are, how do we bring those patients closer to home? So some of the patients who would normally live in Sheffield, who have parents or carers around them, might well be placed in the other end of the country, which is clearly no good for their for the provision of their care. So bringing them closer to home, putting them in as least restrictive setting as possible, and ultimately trying to enable great community services so that we can take them out of those more restrictive settings and rehabilitate them within community. And for those of you who are in the trust and have been looking at kind of dispatches, the specialist community forensic team have now fired up and are now taking patients as part of that service. So next slide, there's a quick clip that, if the technology works, just wanted to quickly show you, which will probably explain far better than my garblings about what these provider collaboratives are all about. So if you can magic
Sorry, I'm just going to come into it a different way, Chris, if you want to just fill the gap.
So this clip that you're about to see was produced about a week and a half ago and is intended to explain and be used by people like myself to explain a little bit more about the programme. So it's 5 minutes. We'll quickly rattle through that and then we'll hand over to Adele. Have we got the volume?
Can you hear it?
No.
Great. Okay, bear with me a second. Sorry, Chris, bear with me a second.
That's okay.
To improve the lives of patients and their families.
Can we hear this?
Yeah, got it, Joe, thanks.
NHS Mental Health Learning Disability and Autism Services. Nurses, doctors, and other clinicians are working hard to improve the lives of patients and their families and carers. Every world-class health service, however, must continuously ask itself how it can be more effective in the future. NHS England and Improvement is committed to continually reviewing the services they provide to ensure we provide high quality and timely mental health care for everyone who needs it. We are also working to tackle inequalities in access, experience, and outcomes. And we believe that our decision-making could be more collaborative and responsive, with patients and their families and carers playing a greater role in the decision-making process than ever before, and having their voices heard from board to ward. We also want more patients to be treated closer to their homes, communities, and the people that support them best. We'd like care pathways to be smoother and to make transitions between different types of services easier for everyone involved. So if it's the best thing for them, patients can return to their friends, family, and community more quickly. This is why NHS England's long-term plan has included extra funds and recommendations to improve the operation and delivery of specialised mental health, learning disability, and autism services. In the past, the decision-making for commissioning specialised services wasn't as integrated as it could have been, which meant the pathways of care could become fragmented. But pilot programs where local providers work in partnership to deliver whole pathways of care proved that a better way is possible. NHS-led provider collaboratives are a new type of clinically led operational grouping, led by a lead provider accountable directly to NHS England regional teams. They will take financial and clinical responsibility for the commissioning of specialized services for their local population, including children and young people's mental health services, adult eating disorders, adult low and medium secure services, and secure learning disability and autism services. These services will be developed by experts by experience in collaboration with local clinicians, local authorities, other commissioners, for example, clinical commissioning groups, and service providers such as voluntary community and social enterprise sector, with the NHS England regional teams providing support and oversight. Provider collaboratives will work with local integrated care systems and strategic transformation partnerships, which means they will be able to remove barriers and smoothly integrate community, acute, and specialized services, as well as design and operate high-quality local care pathways equally accessible to all that better meet patients' needs. The aim is to provide care much closer to home and with the least restriction and disruption as possible. With increased decision-making powers and experts by experience central to the process, provider collaboratives will be more able to implement local patients' and carers' views on how services should be run. Services will also be evaluated in a new way, moving away from the total number of patients treated and towards an assessment based on the outcomes achieved for those patients. By building a collaborative approach, we will improve the sharing of knowledge and resources amongst providers and commissioners and enable continuous improvement in local services. The pilot programs showed that treating patients closer to home, reducing unnecessary hospitalization, and ensuring decision-making involved patients and was clinically led was not only more successful and less disruptive for patients, but was also less expensive for the NHS. This added efficiency frees up additional funds for the provider collaborative to reinvest in the community, helping to pay for much-needed preventative programs and other early intervention mental health services. The provider collaboratives and long-term plan are a direct response to patient, carer feedback, as well as from NHS staff. They represent a moment of real change and an opportunity for each of us to reshape and improve how we work, both individually and together. In fact, there has never been a better time to have your voice heard or to make a difference to mental health, learning disability, and autism services. To find out more about your local provider collaborative, who to speak to if you want to get involved, or just to get some additional detail about how this change will affect you, your care, and your local community, please visit our website today. Further information can be found on the Provider Collaborative website, or just search online for NHS-led provider collaboratives.
Okay, so hopefully that painted a bit of a picture. So I'm going to hand over, when Joe brings the slides back up, straight to Adele, because I'm conscious of time, and I did commit at the outset to making sure that we had a meaningful amount of time for sort of discussion. There will be, when Adele finishes, a sort of a gap for any Q&A that might kind of immediately come off it. But Adele, over to you. Do you want to go to the next slide, Joe?
Thanks, Chris. Just in the spirit of this being the reality of life at the moment, there have some emergency work being done in the house downstairs, so apologies if there's any noise. That's the world we're living in, isn't it? And I'm also in my son's bedroom, so if you don't appreciate the football shirts, I apologise as well. I've tried to get as far away as possible. So, Acute Care Modernisation. The Acute Care Modernisation programme has had various names over the last few years. And those of you that have been in the trust a while will know that it started some years ago in terms of trying to get our acute estate to the point where it is fit for purpose for a high quality, safe environment for our service users and staff. Phase one of that was to build the new PICU at the Longley Centre. And I say new, the word new, 2015, so not quite as new as it was, but it's still very new compared to the rest of our estate. So basically what I wanted to tell you today is what the Acute Care Modernisation programme is now. I think that's probably the most helpful way of looking at it, and where we are really, because I think a lot of people will be quite interested to see where their contributions have gone over the years and how we're acknowledging those contributions and moving it forward to create some extra quality within our environments. So this programme is, yes, it is to bring together services. So it is to bring together acute services. So originally started to look at the crisis services. Originally there wasn't a decisions unit, which we've now got at the Longley Centre, but it's to bring all that together with all of our inpatient acute wards, a place of safety, and the relevant caring facilities around that to make it, I suppose, a flagship environment for our acute services, both from a sort of efficiency and safety perspective, but also to upgrade what we've got now, which if you're part of or go on to our acute wards, you'll know that they aren't in the best position at the moment. And you may also know that we've had various must-dos and should-dos through our CQC inspection around the environment. Could you have the next slide, please, Joe? So what I think the best way to describe the ACM is, yes, it is an estates project. Yes, we are physically ripping out what would be in the Longley Centre and changing that to make it appropriate. However, it is about the environment, but I think we won't be able to make that environment appropriate if we haven't got the right people and clinical practice involved and the right technology to make that happen as well. And so we've been quite clear over the last few months to look at how that all comes together. There's been a huge amount of engagement work gone into this from many years ago, ramped up significantly during 2017 and 18, and Alison at the time and Jeff from Estates did a great job in bringing everybody together to get their views, and that all those views were used for making the plans that we know today, which are the designs of the Longley Centre. Could you move on a slide, please, Joe? So the environment's really important. These are sketches. These are actually the sketches of the rooms that have been designed for the Longley Centre. you don't need, if anybody wants to see these, you are very welcome to ask, and I will make sure you're provided with all of the details. They are quite standard, I have to say, in terms of architecturally, they are quite standard. The reason I'm showing you this is just to say we are looking at putting in absolutely up to spec lounges and bedrooms with en suites to protect the privacy and dignity of our service users, but also to give them the socialisation that they require, and also hopefully the privacy they need when they need it. And I think that's the important point here. So the environment we've got, I think we've got a good position to start from, in that the trust has been very diligent in terms of getting in an excellent design team. And we had actually very recently got to the point where we had contractors who had put in their tenders for this work, which I'll go on to a little bit later. Joe, could we just skip 2 slides, just conscious of time? Don't want to take up too many people. So we've got, technology. So technology. The reason I wanted to go into technology was just to say, when we think of technology, we think of this sort of very advanced technology, and although that's really important, what we found when we did the engagement, for a lot of the engagement for this programme, was that people were actually interested in the more basic technology that we perhaps don't have, or they don't feel they've got access to. So even basic things like newspapers on the wards, which are on a digital format, books, TV programmes, digital format, they didn't feel at the moment they had access to that. Now, what's changed when we started this conversation, and I suppose what's improved and what we've gone through an iterative process from a QI perspective, is that message has changed, but also the world we're working in has changed. And COVID has very much brought about this conversation about how do we get access to the outside world from our acute wards, so that our staff and service users can make sure that they can have that instant access to, say, loved ones or external agencies that they need to contact. And I know the trust work really hard to get in sort of Skype and MS Teams. It doesn't really work particularly well for service users. So we have been looking with IT now, before we even get to the point where we've got the new building, about how we can put a media platform onto the wards, and that's something we're doing at the moment. We did get a load of tablets that we got to the wards during the early stages of COVID, so that patients could speak to their loved ones, and that proved useful. But we want to go a tiny step further than that and make that into more of a media platform. So I guess needs must, but also we're trying to improve the quality as we go, rather than just doing that as an end product. And I think that's what we're hearing, I suppose. That's what we're hearing. If you could move on the slides, Joe. So progress, this is what you all want to know. Where are we? Obviously, we want to provide the best environment, and lots have changed. So we have got a set of designs that have been engaged upon over the last 3 years. They have been through the relevant processes, and we have sent that to tender. During that tender process, a number of our clinical leaders have taken a look at those designs and said, with the current things we know, things we've learned, the things that we want our environments to be, actually they felt that those designs could be improved on further. And to make sure that we have the most therapeutic environment possible, we've taken a decision, and I say we, it's a collaborative decision, and our trust board have agreed that this is the right decision to take at the moment, to review those designs further, taking some of the things we've learned from some of our inspections that we've had, and from, I suppose, also taking into account some of the things we've learned from operating acute environments during a time such as we've got a pandemic around, and what does that mean both for the wards but also for the staff areas. So it's an interesting time for the programme. It does mean rewinding that design process. And I said when I said to Joe, we'll do this and speak to everybody about this, I said we wanted to be transparent and open about where we were. And I think, with all quality improvement, you've all seen that classic slide that sort of goes like this. I don't know if you can see me and it goes uphill and downhill, and you sort of, nothing goes in a straight line. And I think that's exactly what we're experiencing with this programme, is that although we might be trying to go in this straight line to get to the end point, actually we've had to go uphill and down dale to get there. And that's why we're taking this opportunity, I suppose, to redesign. So because of that, it will mean that we are in a period where the end works won't be coming as quickly as we thought. And also because of our current environments being not up to the specification that we require them to be, we are now working on interim improvements for our current wards. So you'll all know that we've started removing our dormitories, which we've now done from Maple and Dovedale 1 ward at Michael Carlisle. We are also then undertaking a programme of works further at the Michael Carlisle Centre. Within the next 3 weeks, we'll be starting work on Dovedale 2, which for those of you who don't know isn't occupied at the moment by service users, but is used for various therapies, etc. But we're going to be turning that into a 12-bedded up to specification ward to help us with further works that we're going to do on Burbage and Stanage wards in order to get those to specification. The engagement into the design so far won't be lost. We're going to keep that engagement. We've learned lots about how things should be and how they should operate. I'm not sure if that's me interfering here or the noise interfering. Can anyone else hear that? Sorry if you can. We're trying to get the engagement into the designs further.
Sorry, Adele, I think somebody might need to just put themselves on mute. I think somebody's, I think it's other background noise as well, if that's okay. Sorry.
Yeah. I'll carry on. Just tell me if it gets, I'm not sure who it is who's not on mute at the moment. So the engagement won't be lost. We've learned lots of things. We're going to use that going forwards, and we will be engaging about the designs at the Michael Carlisle Centre as well. So I think that's me being as transparent and open about the fact that, you know, even large improvement projects will have this uphill and downdale effect, as well as the smaller service improvement programmes that we go through in the trust as well. I think there's just one last slide, Joe. Oh yeah, stakeholder engagement. So I'd already gone on to that. So we've done lots of things, and lots of you will have been involved in all of those things. And we are continuing to do that. It's got a little bit more difficult. We'll all be honest about that. Engagement's got more difficult, hasn't it? Because, you know, you can see my face now, but when I want to engage with the ward staff, you know, it's difficult to enter those environments at the moment knowingly and doing it appropriately. So we're working around that, but it is tricky. And I know Joe's mentioned this to me before, you know, in terms of all projects, all programmes about improvement and engaging with people, it can be tricky, can't it? Because this is okay for this, but there are certain things where you need to get around a set of plans and people want to do that in a very physical way. So we are having to change the way we do that. We have obviously got a formal reporting structure which we use as well, but there are very much, in terms of engagement, it very much is about how we engage going forwards, but also how we get those people who are engaging not to be over engaged with. So we've got the same colleagues, some of them on the call today, who are engaging over the same thing, lots of different things, sorry, and environmental improvement projects, because we've got such a task on our hands to improve those. That's all I really want to say, in essence, that is the programme as a whole. It has grown from what it was originally, which is, you know, the Longley Centre, and it is still about getting the Longley Centre to the position we want it to be an acute care environment. Along the way, there are certain things we've got to do to make sure that we continue to provide a good level of care in an environment that's actually safe and sustainable for our service users and staff. Thank you.
Great, thanks, Adele. So opportunity, I guess, for a few moments of questions, kind of feedback on that, and then we'll segue for the last kind of quarter of an hour, 10-15 minutes into sort of just pondering some questions really in the context of, you know, continuous quality improvement. So anyone, if you want to come on camera, that would be great. If you want to just unmute and speak, equally, if you prefer to put your hand up, do that. But any kind of comeback on either of those two programmes of work, any kind of quick questions that we can help answer. It was obviously so well explained, Adele, that it's answered every single possible question. And I guess one of the difficulties around any build programme of the complexity of yours is making sure, you know, it's seen as a means to an end, but not the end itself. And having worked in construction for 10 years, often, a lot of time and effort and complexity in the building. But actually, when I move into a house, it's not the house that I'm interested in. It's a warm environment, somewhere to have fun with my kids, etc. And I think sometimes it's that kind of underpinning recognition that seeing the wood for the trees of actually, this is going to be a fantastic environment for patients, for carers, for staff. But actually all the complexity that we have to go through to enable that outcome to happen. So, Joe, could you pop the slides back on? We just wanted to create a space really for you to prompt some thoughts and conversation. There is an awful lot of experience on the call, just looking through the names. So if it goes quiet, I might ping a few people to share some of their wisdom and experience. But what we just recognised was that within any organisation that is largely focused around delivery, we bring along a transformation programme that's about fundamental paradigm shift in how that organisation functions, culturally, process-wise, or whatever. And yet the nature of most organisations is that they sit in some form of hierarchical governance that is designed to be perfect for delivering services. And rightly so within an NHS context, we have to be ensuring that quality of care is right, that there's procedures in place for all of that. But they're not always designed, are they, for a paradigm shift in culture or buildings or facilities. So, Joe, could you just go to the spare slide? And I just wanted to, by way of kind of opening up a conversation. This is maybe a little bit simplistic and maybe a little bit clumsy, but I just wanted to sort of share, having worked for about 30 years in a range of different industries, different organisations, largely in a transformational context, so the right-hand side, but existing in a world that's on the left-hand side. And having to work within systems and processes and governance and culture and values that's on the left-hand side, and yet you're trying to go through a paradigm shift and a transformation. So some of those things, as you just scan down, might well resonate. You might have different views, which would be great to share some of those experiences and views. But if nothing else, what I wanted to just do is land this slide as a recognition that if we're doing 6 or 7 transformation programs, which are fundamental to this organisation's ability to deliver exceptional patient care, and yet we work within a context and a confine that isn't necessarily enabling that transformation, what might some of the challenges be? And in the context of a QI week, as we come to the end of that, we just wanted to open that question up really. What are some of the ingredients for success? So if you just go back to the last slide, Joe, and then I think what we will do is allow you just to kind of have a look at some of those points to ponder. And then what we're going to do is we're going to copy those into the comments field, and then we're going to just bring everybody back on screen for the last 10 minutes so we can actually have a conversation with each other. So, what are the ingredients that enable successful and complex transformation? Do you want to pop them into the comments column now, Joe? And then
I'll just do that whilst the conversation starts. Sorry.
Just whilst she's doing that, and purely for the purposes of triggering some thinking in this space. About 10 years ago, I worked at South Yorkshire Fire and Rescue Service for the Chief Fire Officer. It was at a time where the fire service nationally had gone through a significant change in what they were being focused on doing. Some of you might remember the green goddesses all were coming out across the country. And that was fundamentally because the legislation changed the role of the fire service from being firefighting to being fire prevention. Firefighters who were going out onto the fire ground, who were now going into homes and putting smoke alarms up. And as part of that role, South Yorkshire Fire and Rescue Service, you may remember, had a bastion of what was the previous empire of the fire service at Wellington Street, just behind John Lewis. And that was being built that was being demolished as part of the new retail quarter. And at the time, John Lewis were going to go there. And really simply, what I wanted to just emphasize was that building was emphasizing a culture of an organization that was in the past. You were literally as important as the size of your office. There were actually procedures in place that didn't allow you to order a chair unless you're a particular grade to be able to get the size of chair. Now, so the point I'm kind of making with this and segueing in is working closely with that chief fire officer, we moved from that type of environment into a building at Eyre Street, which was completely open plan. And at the time, 95% of staff were resisting that change. And we worked really hard. And the pivotal point to this was we took a large proportion of staff to the health and safety executive offices in Buxton that had just been built. And we helped them to talk through some of the staff who'd gone through a similar journey of resistance, of not wanting to change, into a building that was so fantastic that they couldn't ever believe that they worked somewhere different. And I guess the point I wanted to make as we segue into a conversation is, how do we enable and envision a different world that is better for patients and staff when actually we're often caught in the world that we live and exist in, and actually, if we're honest, sometimes quite comfortable in that space? So I just wanted to use that as a kind of a springboard into pondering some of those questions. And if you look in the comments column, there are some of those questions. So floor's open, really. Any thoughts from people's experiences, any kind of questions on what might some of those ingredients be? Joe, yeah.
Yeah, I don't know if this is really answering your questions, Chris, or more of an observation and something that I think we've talked about before, about when you had the two slides up with the kind of the business as usual, and then you'd got the project. And quite often, and I think Adele might have reflected on this a little bit, quite often it's the same people. So you don't often have the business as usual, there's one group of people, and then you've got the project that's another group of people. Actually, it's the same group of people trying to do it all. So it's not really answering questions, I suppose it's throwing in another challenge in a way, I think. You get the people who have got the skill and the knowledge and the enthusiasm, and it's that same group of people that are trying to do it all. And so I suppose it's kind of creating another question in terms of how we can overcome some of that, or how we can address some of that, really. Yeah, so observation and question back, I suppose.
Yeah, no, that's really valid, and I guess one of the answers that I'd probably, and I'm sure that there's others on the call too who would have views on that. One of the things that in NHS England, when I worked around an organisational development programme, was the importance of champions. We invested heavily in identifying champions across the organisation that we trained and invested in. We inspired through great leadership. And those people were the people that effectively enabled the transformation, because those are the people that were sitting in offices over here and over here, working as finance or as HR. And they were the people that were ambassadors around why the change was important to happen. Without those champions, a lot of those transformations in behaviour, in values, in culture would not have happened. And as the programme lead across that, I can categorically say that. So I think hopefully that's a helpful response in terms of maybe one of the ways in which, as an organisation, rather than burning the same people out, maybe we need to invest in some champions and actually lead and inspire them. Maybe I don't want to change, but actually it's often those people that don't want to change that, if invested in and led well, are the very people that are the pinnacle of making change happen, as you and I, Joe, know from STH days. Conscious a few hands up. Sorry, I didn't quite observe who put theirs up first. So I'm going to go to Jonathan, then Richard, then Mike, and then Robert. So Jonathan, you're on mute. Great.
Hi, thanks. Just wanted to make the point, I guess fairly obvious, really. If you're in what I'd call a stressed mindset, even just the concept of change is very difficult and just needed to be more stressed. And I think this is a real challenge for us as an organisation at the minute. You could argue that as an organisation we're in that kind of stressed headspace. Certainly some of our teams are, and absolutely some of our team members are in that headspace. But we can't really get out of that unless we make all sorts of changes, some of them very big changes like you guys are describing. And it's not a question or anything really. It's just wanted to raise that point of that's a real conundrum that we're in, but we've got to go at it very carefully. That we can't you can't really push people when they're in that kind of fragile state, because you're just going to make matters worse. I haven't got any answers. I just wanted to make the point.
Yeah, Jonathan, thanks. And it might be that others have got some thoughts on that. And I guess, I don't certainly have any quick and obvious answers other than how do we pay attention to that? Because actually in paying attention to some of that empathy of what people are feeling, rather than just bulldoze it through with a timeline and a Gantt chart to say we have to have changed by this date, how does it become more meaningful and therefore engaging? But yeah, thank you. So I'm going to go to Mike.
Hi.
Hi, Mike.
I'm very much on a learning curve here. So I've been in the organisation since the 1st of August, and obviously just looking and listening and trying to gauge where the organisation is, where people are. And these modernisation programmes, you've got a huge capital programme, you've got a huge programme of modernisation at a time when the organisation is under pressure operationally. We've got the whole issue around COVID and the impact that has on on staff, not only in terms of absent colleagues, but also in terms of how we feel and how we're all engaging together, because we're all living through this both at work and at home. I do think there are some things that we can learn. And for me, my experience tells you when you do these programs, somebody's just talked about, we've got the same people doing all of this, same people who are engaging on the design, engaging on the transformation program, but also are at the front line. Now, somehow you've got to involve frontline staff because they need to own it, and it's them that's going to work in it, and we need to work together. So for me, and I don't have any magic answers to this, but for me, it's about time and protecting time to have these conversations and have them sensibly and constructively. It's also about getting some external challenge into it as well. So, some fresh pairs of eyes, some peer review. It's all about us having real ambition. And you're not just saying, well, we've done this forever, we'll just do a little bit more of the same. It's about having that ambition. And it's about really understanding what transformation means in terms of whatever we're looking at. What's the best evidence-based practice? Where are there examples of some good practice elsewhere in the system? Because we tend to just keep reinventing the wheel. And somebody somewhere else will have done this and will have done it well and will have learned from their experience. So, how do we try and capture that and not just all of us continue to reinvent the wheel? But I do think, the building is only the building. It's the people inside it that actually make a difference. And somehow we've got to get that balance right.
Yeah, thanks, Mike. And again, lots of points there that I think, what I heard very much underpinning a lot, it's the relationship piece and actually building some of those relationships between people in the organisation. And doesn't COVID make that difficult? I'm a highly extroverted person. I find it really difficult to be at home on Teams. So just, and I guess one of the questions that kind of back to, and maybe Joe can follow up with the team is, Mike, you make the point about how do we create space like this? This is 45 minutes within a QI week, and we've got maybe 10 people on the call. How as chair, how as other people on the call, as leaders in the organisations, can we intentionally create space where people can actually have these sorts of conversations? And maybe that's an action we can sort of take out of this as how do we support some of that conversation?
I think as well, Chris, we need to prioritise, because again, we're not very good in the NHS about stopping doing some stuff. We just keep piling more on top of more on top of more. And when organisations are under pressure and under stress, if we continue to do that, it just makes it worse. So somehow we've got to step back and say, right, what are the real crucial things that we need to do as an organisation? And we might have to say we're going to have to stop or step back or reprogram some of these other things, because we just cannot do everything all at once. And I don't know how effective we are as an organisation yet at doing that.
No. Okay. We have been given an extra 5 minutes by Joe. So I'm conscious that we've got a few more hands up. If you are able to stay, please do. But we're not going to get suddenly cut off and entered into the next QI session on health and safety. So I said the next was Richard, and then I'll come to Jonathan, and then Gerke. I can see your hand up too. Richard?
Sorry, my hand's not up.
Oh, sorry. Okay, I thought I did see it up.
Is
okay.
it Amy Richards?
Sorry?
Is
it's
it
Amy Richards?
No, I saw it. Okay, yeah, sorry. Yes, well, Amy, you take it away, Amy.
Thank you. I was just responding to the sort of first point that Joe put on the side, the bullet point of what are the key ingredients that enable complex transformation. And it kind of follows on, I think, quite nicely from Mike's point about the relationships. I think a big part of that is the communication. So I think for me, a massive thing with any transformation program is the communication. And I think from sort of my experience working in this organisation and other NHS organisations, I think if you get the communication right, that's a massive help in terms of the whole programme, sort of if you get that right from start to finish. And just sort of as an example, I think the ACM programs have been sort of very well communicated from kind of floor to board, as ward to board, as is the sort of common term these days. But I think other programs not necessarily been so good. For example, this sort of leaving Fulwood. Fulwood's my base, and I still have no idea what's going on with that. And I manage a team that don't know what's going on with their workplace. They don't know if they're still going to be in the same place in the next sort of few months or few years as the sort of program's been going on. So I think communication is a kind of make or break for me with these transformation programs.
Great, thanks, Amy. And again, I think there's a session in its own right, isn't there? Communication as a two-way process. And I think sometimes organisationally, and certainly I'm at fault at this, is I'm expecting to be communicated to, but I don't always necessarily take my part in communicating out. So really helpful point, Amy. And again, maybe something that we can pick up. Jonathan, you had your hand up and now it's down again. Did you want to say something? We have got a few more moments and then I'll go to Gerke as the kind of final points.
Sorry, I forgot to take it down earlier.
Okay, no worries. So Gerke, sorry if I pronounced that wrong.
That's quite all right. It's Gerke, but you know, that's sounds near enough, Chris. Thank you. Yeah, just to really follow on from Amy's comments with regards to communication. So being in my clinical role, you know, having worked as a speech and language therapist, you know, that importance of communication, but also really linked to, you know, we talk about communication, but it's like the choice of language. So I know, Chris, you know, used the metaphor of the chair. So there's language in the verbal sense of, you know, how we choose our words, what abbreviations we may be using, and thinking how we connect, you know, kind of to service users, to staff, but also higher up in the organization is kind of just being mindful, you know, where people are at and kind of really adjusting the language we use and kind of also, you know, communication and language. It also links to listening. So kind of which then links to time. That sense of making time to really care. And that is, you know, obviously we are all there to care for the service users, but also, you know, it's the staff to really kind of being mindful what change means, what the impact of change is, and that linking back, you know, to Jonathan's comment about stress. And, you know, culture change, it does take time.
Yeah, absolutely. I'm mindful that we run over slightly. I think the recording is there, and Joe, I know you had to dip off for a moment, but there's a few things I think that we can reflect on from the conversations. Some of what Mike was saying about creating some more space, some of what Amy was saying, and maybe we can have some conversation with people like Holly and others. So just kind of to finalise the session, really, just to proffer an idea. It's not necessarily based on huge wisdom, but one of the things that I've observed in many years of working in transformation programs in organisations is that there's often an ingredient that when you pull together becomes greater than the sum of the parts. And Joe will remember from my STH days, I used to have this a formula above my desk that said 1 + 1 = 3. And I think often with me, transformation within an organisation is about trying to get a formula that is about each individual, when combining with others collaboratively, becomes greater than the sum of the parts. And for me, around transformation programs, there's 3 particular parts. One of which is the program rigor and structure, which sometimes is a PMO type function. One of which is the OD and the culture and the values piece, what's underpinning how we do things. And the other is around continuous improvement. And Joe will know from, again, STH days as being part of the sort of the team bringing the Microsystems Academy into Sheffield. Those 3, when added rightly together with the right relationships and set with a leadership framework, I think can set on fire organisations to transform. So you might agree, you might not agree, but unfortunately we're out of time. So answers on a postcard if you have any other thoughts. The thread, I think, will continue, Joe, is that right? So if people want to continue the chat in the comments bit, please feel free to do that. But really, other than that, apologies we've gone over. Thank you for engaging in conversation. Joe, back to you. I'm not sure whether there's anything. Oh, and thank you also for Adele. I'm not sure whether you, wave without the noise in the background.
They've stopped drilling now, of course. When I stopped talking, they stopped drilling. Yeah.
Joe, so over back to you.
Yeah, well, no, you finished really, Chris. I'll just take the opportunity to say thank you to both of you, Chris and Adele, for using this space, and for everybody for the contributions as well. So like with all of the sessions this week, I think they kind of end with a lot of thinking, and I don't want it to be that kind of we have the conversation and that's it till next year, till the next event. Actually, let's keep in contact, and absolutely Adele's put in there about communication. So brilliant. Yeah, thank you to everybody. And there are a few sessions left. If you've not joined up, we've just got a few sessions left for today, and then been a great week. So, and we'll be sharing the recording. So thanks ever so much.
Thanks, Joe. Thanks everybody.
Thank you.
Have a good day.
Thanks all.
Thank you very much.